question. How many half-used beauty products are currently living in your bathroom drawer? Too many, right? That's where U Beauty comes in. We test everything from supermarket finds to luxury splurges and tell you what's worth it. U Beauty, saving your skin and your wallet. Listen now wherever you get your podcasts.
You're listening to a Mamma Mia podcast.
And can I just say, whoever helped us make that transition, thank you, because if I never have to experience that scraping sensation on my uterus ever again for the rest of my life, I will be eternally grateful. Hi there, friends. This is Well Australian Women. Welcome to your full body health check. I'm Claire Murphy, your resident journo, who is attempting to gather all the correct information about your health that I can find so you do not have to read the internet from the front to the back in order to try and find what's true and what isn't.
And I'm Dr. Mariam, and I've got to say, one of the things I love most about my job is that every day something new comes about. Medicine isn't static, it's constantly evolving, and to keep up, I'm learning right alongside you.
Like, you literally can never just know everything about the human body.
No.
It's an endless delight,
I love
as we
it.
find out in med school every week, right? In today's quick consult, we have a spring-related question from Liv, and it's not about the allergies so much, but more about the medication and how it might be affecting lubrication in certain parts of her body.
The vajayjay.
The vajayjay. We're also catching up with Professor Clare Scott to talk about a couple of cancers that might turn up in our uterus and in our ovaries, what causes them, how to spot them, and how to treat them, including whether there are any new ways that we're looking at now that might help with testing to catch some earlier, because that is one of the main problems with ovarian cancer. And we should actually take a moment here to send all our love to Anastasia Katsalis. If you've watched Gogglebox, you would know her, in my opinion, one of the funniest humans on the TV. She was recently rushed to hospital and had an emergency hysterectomy because of uterine cancer. So we're wishing you a very speedy recovery. We hope it's all going well for you. And for anyone who's currently dealing with this situation right now, we're thinking about you. We know it's not easy and it can be a little bit scary. But next, if you are iron deficient, we're told all the time to focus on what foods we are eating and if your doctor prescribes you supplements, what supplements you take. But I heard that what you actually cook your food on might also make a difference to your iron levels. We'll find out what that is next when we head to med school.
Let's do it.
Welcome to med school.
Mariam, are you iron deficient? I feel like every woman in my life is right now.
Is that a silly question?
I actually think it is. I feel like we should just presume that everyone is iron deficient and rule out those who aren't.
Yes, I've got iron deficiency anemia as per yesterday's appointment with my obs-gynae, but this time it's actually pregnancy related. We know that iron is the MVP in your body. It's key for red blood cells, the oxygen courier for both you and Bub, and it's also vital for Bub's brain development, immune system, and overall growth. So yeah, growing a little one is a serious energy and iron party.
It is one of those things, because I've been iron deficient since I was a teenager.
Yeah, same.
And so I've been on supplements for a really long time. I've been told many times, and I presume you have too if you've been dealing with this for a lifetime, is like, make sure you eat iron-rich foods. You need to have red meat in your diet. But there have been multiple studies over the years that show cooking your food in an iron pan or skillet can increase the iron levels in the food itself that you are cooking. Now, this doesn't help if your issue is iron absorption, so if you're celiac, for example, because the iron you get from the cookware is non-heme.
Yeah, okay.
And heme is what you get in like red meat, which is what your body really enjoys absorbing. Yeah. And so that iron pan, non-heme iron might just get expelled later on because it's not as efficiently utilised by your body. And in fact, iron is a bit of a pain in the ass, to be honest, to keep your levels up because your body's a little bit picky about the source. But cooking in a cast iron pan can help at least increase the amount of iron that's in the food that you are consuming, which is great. And there's also this other little gadget. It's a little iron fish.
I've seen those.
That you can chuck in pasta when it's boiling or in soup if you happen to be heating it up, and that can also put extra iron in your food too.
So you're right. Cast iron pans, then that lucky iron fish can boost that non-heme iron in your meals. It's a really really handy tool, especially if your dietary intake is struggling. But just remembering that they're tools, they're not cure-alls. So real effectiveness comes when you pair those iron-rich foods with vitamin C, like your broccoli and peas. That allows for better absorptions, especially if you're a vegetarian or a vegan. I am going to use this moment, Claire, as a PSA, if that's okay. So many people come to me and they're iron deficient and they're on these supplements and they've been on them forever, but they don't know why. So replenishing your iron levels, very important, but it's just one side of the coin. The other is figuring out why you are iron deficient in the first place. Otherwise, we're just giving people a Band-Aid solution with iron supplementation.
And the problem is too, as women, because we bleed once a month for years and years and years, often that's just what it's put down to.
And a lot of the time when I do see people with iron deficiency and I'll ask about their menses and their menstrual cycle, some will be like, oh, I bleed for 3 days. And I'm like, well, it's not your period. We've got to look for a deeper issue. And here's what I look for when someone has iron deficiency. So number one is inadequate intake. So it might be dietary choices. Are you vegetarian? Are you vegan? Are you picky with your food? Are you missing meals? Aussie stats show that 40% of teenager girls don't meet their iron needs. The second one is poor absorption. So conditions like you mentioned, celiac disease, inflammatory bowel disease, previous bariatric surgery can all mess with how much iron your gut absorbs. Celiac disease alone accounts for about 1 in 20 cases of unexplained iron deficiency in Australia. And then there's blood loss, and that often flies under the radar. So it could be heavy periods, but a lot of the other time it could be the gut. It could be the upper GI system. So if you have iron deficiency and you don't know why, please see your GP and learn the why. It is very important.
All right, let's get into today's checkup. We're looking at cancers that can impact your cervix, uterus, and ovaries to get the lowdown on symptoms, testing, and potential treatments.
Let's do it.
It's time for the checkup.
All right, let's tackle this straight up. Cancer can be a really scary word, especially if it's something that we hear in relation to ourselves or someone that we love. But the reality is it is something that we may have to face in our lifetime. So today we're looking at 3 cancerous areas. We're talking about uterine cancers, cervical cancers, and ovarian cancers. Let's get this one out of the way first. Ovarian cancer is the deadliest women's cancer in Australia. The latest stats show a 5-year survival rate of just 49%, which is not great. Part of this is because ovarian cancers, 2/3 of them, in fact, are diagnosed at quite an advanced stage, where survival drops to just 29%. Despite significant advancements in treatment, progress in ovarian cancer survival has stalled. So women getting a diagnosis now basically have a very similar prognosis to women being diagnosed about 50 years ago. So there hasn't been a lot of progress since then. That is the scariest one out of the way first. Uterine cancer, though, is the most diagnosed cancer for women here in Australia. It's often referred to as endometrial cancer, and that's because that's what the lining of the uterus is referred to as. The average age for diagnosis of a uterine cancer is 65, so it is generally when you do start to get a little bit older. Case numbers of uterine cancer, though, have doubled in the past 20 years. Numbers are growing in both older and younger Australian women. There is a suggestion that this could be linked to lifestyle, and I think this is what a lot of the things we discuss comes back to. And so we're looking at things like obesity and type 2 diabetes contributing to that. Now, the one we probably know the most about due to the vaccine for HPV making a significant impact on numbers is cervical cancer. Now, that's the one we used to get a pap smear for, and now we get a cervical screening. And can I just say, whoever helped us make that transition, thank you, because if I never have to experience that scraping sensation on my uterus ever again for the rest of my life, I will be eternally grateful. Since the vaccine program began in Australian schools back in 2007 and then later included boys because they also get HPV and can spread it around, precancerous abnormalities in women of the cervix aged 20 or younger declined by 70%.
It's amazing.
Between 2006 and 2016, and 47% in women aged 20 to 24, which is remarkable. And I also just read about a Mexican scientist. Her name is Eva Ramon Gallegos. She is the first person in the world to eradicate HPV in 29 patients.
Wow.
So her breakthroughs come after years of research. if we can eradicate HPV entirely, then it could lead to another drop in cervical cancers, which is amazing.
Amazing.
Yeah. Now, Mariam, can we talk about cervical cancer first? You are a huge advocate for the self-administered test. Can you talk us through how that works and why they have become so important?
Yeah, sure. So I love and I'm a massive advocate for the self-collected HPV testing. And it's not just because it's easy and convenient, but because it's transforming access to cervical cancer prevention right here in Australia. We know it's highly preventable, but yet 70% of the cases that happen to people who have been under-screened or never screened. And that's not okay. So with the rollout of the self-collection and Australia's strong HPV vaccination program, we're headed towards a really great goal. Australia will be the first country in the world to eliminate cervical cancer by 2035. And that's if we leave no one behind.
That's a little
Isn't that
round of applause.
amazing? Yeah. So self-collection, it's not just another testing method. It's an empowering choice, especially for people who haven't felt safe or comfortable or understood in clinical settings.
What kinds of people is that?
So people from culturally diverse backgrounds, people who have had, previous trauma, maybe sexual assault, people from the LGBTQ community, all sorts of different people.
I can't imagine going into your doctor's office if English is not your first language and having to navigate that whole experience because it's uncomfortable and kind of weird at the best of times, right?
That's right. So you get that reminder and you're like, no, I'm not going in for that, but you get offered a self-collection. It's quite empowering to have that opportunity to do it yourself. So if you're aged 25 to 74 and you're overdue or due for your 5-yearly cervical screening test, you've got two options. So you either pick up the self-collection kit from your GP or healthcare provider and you do the quick swab, and it's super easy, and they'll explain how to do it. I call it the COVID swab for the vagina.
If we can almost poke our brains out for a COVID test, we can figure out how to do a cervical smear,
it's quite easy. Or you can stick with the traditional clinician-collected sample. It's totally your call. I don't mind which one my patients choose. They're just as accurate as each other. So please, if you're overdue or you're due and you've got that reminder and it's on your list, prioritize it. Just get it done. It's super easy. Book that appointment in.
So how do you actually get HPV? And if you have been diagnosed with it, should you still get vaccinated?
Yeah, great question. So HPV is a virus that we can pick up from sexual contact. So it's not always penetrative sex. This is a common misconception that you need to be having sex with a male to get HPV. So females that have sex with females can also get HPV. So any sexual contact, and not always just penetrative sex. So oral sex included. To answer the second part of your question, yes, because the HPV vaccine does not treat existing infections, it prevents future ones. It's most effective when given before sexual exposure, which is why we target and vaccinate that 12 to 13-year-old group at school. The vaccine targets 9 of the high-risk HPV types.
Okay, so there's lots of different types.
There's lots of different types. So those 9 high-risk types, that causes over 90% of cervical cancers,
right,
which is why the vaccine's not 100%, okay? And just to add, if you have already had HPV or have it, the vaccine won't help clear it, but it will protect you against other strains that you may not have yet encountered.
So if you happen to have missed the school one, like say you were slightly older at the time, should you go do a catch-up vaccine?
So absolutely. If you missed it at school, you can catch up for free if you're under the age of 25, under the Australian National Immunisation Program. A single dose is recommended for people aged 9 to 25, and it's proven to be just as effective. But if you're older than 25, it's less routinely recommended. But individuals at high risk, for instance, people who are immunocompromised, they may still benefit from it. You'll need to chat with your GP because there might be a private cost attached.
Okay. So what happens though if I do have an abnormal result?
Yeah, okay. So great question. First things first, I want to make it clear. An abnormal cervical screening result is not a cancer diagnosis, okay? So most cervical cancers develop really slowly, so over 5 to 15 years.
Is this when they use terminology like precancerous?
Well, not even. So sometimes we just detect HPV before there's been any cell changes. So we're just looking for the virus with the test, right? And the virus can cause the cell changes, which can become precancerous, which can then lead to cervical cancer. So it's all about early detection and proactive care. So what could different results mean? So sometimes you might get a call back and say it was an unsatisfactory test. This rarely happens, but it can happen. Simply means the lab couldn't read the sample. Maybe there weren't enough cells in the sample. There was a technical hiccup. It doesn't mean something's wrong with you. It just means we need to repeat in about 6 to 12 weeks, okay? The second one is it might say HPV detected, no further action now. So you've tested for HPV, but potentially the lower risk HPVs. Right. There's no immediate cause for concern. Many of the HPV infections resolve on their own. I call it like the genital flu. Lots of people will get it and your body will eventually...
I had a weird vision of my cervix coughing, but okay.
But your body will just clear it. So what we do is we repeat the test in 12 months, and if it's cleared, you go back to routine screening, and if it's not, then we'll dig a little bit deeper.
Okay.
The third thing is you've tested positive for the HPVs that are more likely to cause cervical cancer, so those types. So if your results show those high-risk HPV types such as 16 or 18, or there are cell changes that might have been detected, we'll refer you to a specialist for a colposcopy, and that's just for a more detailed look at your cervix using like a magnification and possibly a biopsy if needed. It's not a cause for alarm. It's just part of following up properly. The follow-up is so important because cervical abnormalities are surprisingly common. Many females will have them and many will resolve on their own, but if left unchecked, some can progress. So it's why those follow-up appointments are so important, not just for your health, but for your peace of mind as well.
Okay. So that covers off our little chat about cervical screening, and we are so grateful for the population-wide screening that we do have now because we've seen just how much of an impact that can have. But ovarian and endometrial cancers don't have a screening process like that at this point. So we're going to get the lowdown on both to see where we're at with Professor Clare Scott next.
Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
Professor Clare Scott has a lot of titles next to her name.
Love it.
She is a medical oncologist at the Peter MacCallum Cancer Centre and the Royal Melbourne and Royal Women's Hospitals. She's Joint Head, Clinical Discovery and Translation and Lab Head at the Walter and Eliza Hall Institute of Medical Research and Professor of Gynaecological Cancer at the University of Melbourne. So,
she knows her stuff.
She knows her stuff. Something you mentioned to me before we started talking on the record is that there are a lot of types of gynecological cancers. Can you give us a quick overview of just how many there are and which ones we should be the most concerned about?
Sure. We think about them in 5 big baskets, really. So ovarian cancer is probably the best known, but uterine or endometrial cancer is equally important in terms of numbers. Then there is cervical cancer, which we need to talk about in terms of screening, and vaginal and vulval cancers. So if you think about those 5 big boxes, in fact, within each of those, there are many types, how they need to be treated, how they need to be thought about, and why they develop. So there's actually about 230 types of gynecological cancers. And of women who have a lethal gynecological cancer, nearly all of those women will have a cancer that is technically rare. So some of those we do a lot of work on, like the major type of ovarian cancer, the major types of endometrial cancer, and the main type of cervical cancer. But there are many women who are actually getting a diagnosis that is not one of those main types. And for those women, we have to really be innovative about how we approach their care. And the problem with gynecological cancer is that because so many of them are individually rare, the approval of what I call 21st century medicine is lagging really woefully behind.
Well, can we focus a little bit in on ovarian cancer first? Why is it so hard to catch early? And are there some common symptoms that we might be able to view as potentially giving us a heads up that we might have ovarian cancer, because there's no direct screening for it like there is for cervical cancer?
That's exactly right. And there are a couple of things that we could touch on. The four main issues would be that, the ovaries and tubes are actually really quite deep in the pelvis. And so when something starts to grow, it doesn't cause any trouble. It is asymptomatic. So you don't actually get a symptom until you've got a larger cancer there. And then the symptoms can be really non-specific. So it can be things like bloating, and we can talk about those more in a moment. The next most important thing is that we don't have a reliable screening test, unlike for breast cancer or for bowel cancer. And so that means that the tests that have been done previously that people might be aware of, they've not been shown to improve survival. And that's really the main aim of a screening program. The final thing, which is difficult with ovarian cancer, is that if it is this type of ovarian cancer that is one of the many lethal types of ovarian cancer, once they get going, they do progress, unfortunately, quite quickly. So even though we would say we'd like to get diagnosis happening earlier, it's actually really hard to do that.
Can we touch on some of those symptoms? Because as I've been scrolling my TikTok and seeing a lot of women talking about either their own experience or their mum's experiences, there was a lot of symptoms that they included. And this has made me understand even more why it is difficult to catch this early, because a lot of them could also be symptoms of perimenopause. So there's like heartburn and reflux, fatigue, feeling full all the time, bloating, as you'd mentioned, rapid weight loss, maybe painful sex. Like there's lots of things that could be something else.
And needing to pass urine more often or suddenly. You've done a really great list of symptoms there, and there aren't many additional ones other than maybe sometimes lower back pain, a little bit of abnormal bleeding, pain during sex or intercourse. And so along with those other ones that you mentioned, particularly this bloating, feeling full early, feeling like you really can't eat a proper meal, unexplained weight loss. These are the things that women may well talk to their girlfriends about. They don't necessarily want to talk about some of those more private symptoms with other people. And what I always say is if symptoms persist, then persist in seeing a doctor. So there's a couple of things to that line. How long is persisting? So, certainly 2 weeks. Sometimes women go to the doctor, so then they've had symptoms for 2, 4, 6 weeks while waiting to see a doctor. And that is certainly excessive. So 4 to 6 weeks of symptoms, they must get to see a doctor, and they must impress upon the doctor that these symptoms really have been persisting, so that even though the doctor might think that that might just be fairly generalised, there are tests that can be performed. And if the doctor you're seeing doesn't seem to be in sync with how you are describing your body, then I think it's fine to go see a different doctor.
A lot of the questions around this that we've been approached about is how ovarian cancers affect fertility. And I know that you've mentioned there are a lot of different types. Will all of them impact fertility? Do some of them impact fertility? Do they impact fertility at all?
Yeah, so depending on the type of ovarian cancer, the choice of surgery and then the choice of treatment, including chemotherapy, they are the really big impacts. So there are some types of ovarian cancer where only one ovary needs to be removed. And particularly for a young woman who hasn't yet finished her family and or hasn't reached the age of menopause, fertility preservation will be high on the agenda for the doctors involved. And then there will be specific discussions about that. If, however, both ovaries do need to be taken, there are some things that can be done, and there are fertility preservation options, including having eggs frozen, for example, before treatment begins. There are more complex versions of that, and those can be discussed with specialists at the time. So I think that decision about whether both ovaries are going to go, very sadly, sometimes that's a sudden decision. It is possible for one ovary to be taken and the other to be left for a discussion. But if a woman is advised that both ovaries need to be taken at the time of first surgery, then that is very difficult.
Now, we've mentioned that there's no general population screening for ovarian cancer, but for those people who might have a genetic predisposition for it, people who maybe test for the BRCA gene, which is mostly linked to breast cancer but can impact the rest of your reproductive system too. Aside from that, is there any other kind of genetic screening or testing that we can do? I've been reading about a blood cancer marker test that some people have been talking about.
So I guess for the high-risk population of women, so women who have a family history or have been identified as having a mutation in their blood for BRCA1 or 2, in fact, those women were heavily included in the trials that have been performed for screening, and the screening wasn't effective for them either. So what we do instead, if we know someone has one of these genes and has a higher risk, and actually about 20% of ovarian cancer is accounted for by those genes. So even though breast cancer is always more talked about and better known about, it's one of the most important ways of trying to prevent ovarian cancer, the only way really. So that is, if a woman is known to carry a gene change in BRCA1 or BRCA2, then we have discussions with her about the time of having both the ovaries and tubes removed. So ovarian cancer starts actually in the ovarian tube. Having both the ovaries and tubes removed when a woman has completed her family and is getting towards the age of natural menopause. So depending on the gene, there are some slight variations in timing, but if you do remove both ovaries and the tubes, it reduces the risk of ovarian cancer by 90% for those women. So that is very effective surgery. But if you can finish your family, having those ovaries and tubes removed is the best way to protect yourself from ovarian cancer.
Why do you think the survival rate for ovarian cancer in Australia is seemingly stalled? Like we've seen other cancers improve quite significantly in some cases, but ovarian cancer not.
There's a couple of issues. So, for example, about 2/3 of women diagnosed with an ovarian cancer are diagnosed with an advanced stage cancer. And there, the survival rate is about 30% at 5 years. And that just indicates how aggressive the cancer is. So we have made some progress, particularly with these BRCA-like cancers, where we've got this new drug, a PARP inhibitor therapy. And we know for some of those BRCA-like cancer women, they can actually get a very good first response to first-line maintenance therapy. So they have the surgery, the chemotherapy, and then they go onto this targeted therapy. That's approved in Australia. That's been one of the real advances. But these complex cancers then go on to develop modes of resistance. So many of us are working super hard on trying to understand that. And I think breaking that nexus is required for someone to be cured of ovarian cancer. There are many other types of cancers, some cervical, some endometrial, where immunotherapy is helpful. In ovarian cancer, it's fleetingly rare for immunotherapy to actually be effective. And that is the absolute urgent need for all labs right at the moment to try to work on that.
If we shift into endometrial cancer and have a look at the symptoms surrounding that, because again, scrolling TikTok and seeing what people experienced, there's quite a few crossovers between endometrial and ovarian cancer, so that bloating that we talked about, irregular bleeding, but also a lot of people mentioned chronic fatigue-like symptoms, a persistent cough, which is really interesting, and then some people mentioned that they had a real increase in mucus or discharge in the lead up to that. Would you say that they are common symptoms?
Just to be absolutely clear, abnormal vaginal bleeding is the most common symptom. So that could be irregular periods or postmenopausal bleeding, and any of that sort needs to be investigated. So you know what you're usually like. If you've had a very stressful time, you can suddenly get abnormal bleeding, but even that shouldn't be put down to that stressful event. It is very easy to have abnormal bleeding checked. So in fact, the lethargy can be as a result of anemia, as a result of abnormal bleeding. We want women to go to their GPs if they have abnormal bleeding. You mentioned a cough. Sometimes that can be a hormonal thing, I guess, with the increase in mucus, but also it is possible for endometrial cancer to go to the lung. It usually sits pretty in place in the pelvis, but the one place it can go is to the lung, and so any cough should definitely be investigated.
Can we talk about some of the main risk factors? Because there's been a lot of conversation about our lifestyle having a role in endometrial cancers, like obesity, smoking, drinking alcohol. Are those things really what we should be focusing on when we look at decisions we are making that could maybe actively see us avoid endometrial cancers?
The absolute biggest thing for endometrial cancer is weight gain. And as we know, weight gain is so common in women throughout life, and towards and after the time of menopause, women who've not gained weight previously can then gain weight. And we know that the risk of endometrial cancer goes up directly correlating with obesity particularly. And this is because fat tissue is where other hormones in our body can be converted into estrogen. And then you have a higher level of estrogen in the body without as much progesterone. You probably know from the pill, there's estrogen, progesterone, they need to be in a kind of balance, because otherwise the lining of the uterus, which is the endometrium itself, it gets overworked essentially. And that is when you get more inflammation and the increased chance of a small endometrial cancer beginning and then being able to grow. So reducing weight is incredibly important. I mean, exercise is another huge issue. Getting out and moving, not being sedentary, getting those steps racking up on your phone or your watch, making sure that you are walking, park further away from where you're going to force yourself to walk. So I can't stress enough these lifestyle factors that can impact on endometrial cancer particularly.
Can we mention too, a lot of women are talking online now saying that they didn't realise that having something like PCOS or endometriosis increases their risk of endometrial cancers. Is that true?
I think it's good to talk about the two things differently. So polycystic ovary syndrome actually functions a little bit like what I was talking about before with too much estrogen and not enough progesterone. So polycystic ovary is a situation where ovaries are not responsive to estrogen, so you end up getting too much estrogen produced without the progesterone coming up at the same time. So in fact, that increases the risk of endometrial cancer rather than ovarian cancer. And it might sound a little bit counterintuitive, but endometriosis, which sounds like it's endometrial, actually increases the risk ever so slightly of a couple of types of ovarian cancer. But in both those cases, the absolute increased risks are small. And the majority of women with polycystic ovary or with endometriosis will not go on to get cancer. And that's the most important message to give.
Why does the risk increase when we are postmenopausal?
Again, that's probably due to changes in hormone levels. Those hormone levels do drop after the ovaries completely run out of steam. And of course, we have the general aging factor. So our organs age as well. So if you think about it, our endometrial lining, our uterus, has been working really hard all our lives. So those cells, just with other cells in our body, do undergo change as we age. We know that exposure to alcohol also is probably more of an issue in the menopause, although some of the ovarian cancer data suggests that it's at any age. But we do see that risk. So inflammation may be related to that too.
Just wanted to finish on whether our cultural background actually impacts whether we survive a cancer, ovarian or endometrial. I was reading that Black women in particular are more likely to be diagnosed with the more aggressive forms of endometrial cancers, for example, and that they are diagnosed much later. Why is that?
So if, as a Black woman, you have a chance of getting endometrial cancer, you will have a higher chance of getting that rarer drug-resistant type. And even though we give the chemotherapy, which we have proven provides some benefit, it doesn't actually cure the cancer in most of those stages. We don't quite understand why Black women have an increased chance of getting that type of endometrial cancer. And in comparison, Asian women are less likely to get those more difficult types. So there are definitely changes in our background cultural DNA, or, of course, potentially environmental changes. But this actually is regardless of where, for example, a Black woman lives. Whether she lives in the US or the UK, these changes both occur. So then if we come to the more difficult question, which is about attention to symptoms, getting in to see a doctor, having your symptoms be listened to, getting the appropriate screening, really pushing to try and get the best diagnosis as early as possible. In the US, there was a veteran study. Those Black women were still diagnosed later, and that wasn't related to the endometrial cancer type. So that means that we do have biases potentially in how we regard women or people of different races, and we have to be incredibly careful to deliver the same care for all.
So as Professor Scott touched on there are some cancers that impact women the most, but they're not getting the funding that they deserve. So we do need to make sure that that money does go towards these types of cancers too, especially ovarian cancer, which is killing Aussie women much earlier than it should.
even for many females, the symptoms might seem small and not worth seeing a doctor about. But if they're new and they continue, I'm really urging all females listening to this, please see a doctor. Just get that peace of mind and reassurance. You are your biggest advocate. And if it doesn't feel right for you, then it isn't right.
Yep, for sure. All right, it is quick consult time next. Could the medication that you take to handle your so fun spring allergies actually be impacting how lubricated you are downstairs?
Let's do it.
It is quick consult time. If you want Dr. Mariam to steer you in the right direction with a health issue that you're dealing with, hit her up by sending through a question. It is time to welcome us into the rooms today. Please do the honours, Dr. Mariam.
The doctor will see you now just through here to consult room 1.
Thanks for waiting. How can I help you?
So Liv's a bit like me, and I'm sure many of you listening to this right now who have to arm ourselves against the incoming spring season. It's beautiful, babies abounding in fields, and those of us with allergies are in the corner itching and weeping from the eyes. But the dilemma that Liv has put to us today doesn't actually have anything to do with the sneezy, itchy, runny side of anything today. Rather, the impact that the medication that we take to combat it is. This is what she wrote.
I was speaking to a friend of mine about how we both have to take a ton of antihistamines in spring because we're both hay fever girlies. But she mentioned to me that her GP told her that antihistamines don't care which membrane it's drying out, whether that's in your nose, your eyes, or even your vagina. I do sometimes have issues with it being a bit dry down there. To be honest, I haven't really paid attention to what time of year that seems to happen, but could it be my antihistamines doing it?
Love this. So antihistamines work by blocking histamine, but they also reduce secretions across the entire body. So that means the mucus layers in your nose, in your mouth, in your eyes, and yes, in your vajayjay.
Oh my God, I sometimes get dry mouth when I'm taking antihistamines.
That's right. Yeah.
That's why.
That's right. So that's the mechanism behind the complaint, that they're drying everything out. So some women do report vaginal dryness while taking antihistamines. It's not a universal complaint, but it is a known side effect. They're thought to constrict blood vessels, reduce circulation, blunt secretions, and that includes the vaginal lubrication. But a quick refresher, other things can also cause a dry vagina and not just antihistamines, so we want to make sure it's not other things. Is it hormonal related, low estrogen? Think of conditions like menopause, postpartum, or certain contraceptions. Other medications, we know some antidepressants, decongestants, and heart medications can also have some drying side effects. And products like scented soaps, irritants, they can all upset the balance down there as well. So what next, my friend? So let's talk timing.
Because we are not taking antihistamine in spring.
I understand. I want you to notice when the dryness flares up, especially if it coincides with your antihistamine use. Consider alternatives. So there are some antihistamines that cause less dryness, second-generation ones that you can talk to your pharmacist about, or maybe you can try the antihistamine nasal sprays instead of the pills. Hydrate and lubricate. So staying hydrated helps everywhere. Plus a simple water-based lubricant can offer relief if needed. And review your medications. If dryness persists, let's reassess your allergy plan. Maybe we can switch treatments or adjust the doses and look at different factors. So if it's an ongoing reoccurrence for you, it's affecting your quality of life, definitely see your GP.
Thanks heaps for that, Liv. And remember, if you do have a question, you can send it through in a multitude of different ways. You can hit us up old school. It's lovely that email feels like old school now, not snail mail. well@mamamia.com.au is our email address. Hit us up in the DMs. I have great chats with people in there. It's been really fun. Or if you want to remain anonymous, you can. You can tell us you want to remain anonymous in any of these ways. We won't use your name if you don't want us to. But the waiting room, there's a link to it in our show notes. It's like an online form. But if you have the patience, you can be Mariam's patient. See what I did there? Hilarious. But just remember too that the advice that you've received here today is general. We love Mariam to the bottom of our toes, but she's not our doctor. Certainly don't take medical advice from me. So make sure you get yourself off to your own GP so that we can take that general advice, arm ourselves, and find out exactly what is going on with you. Next week, we are looking into bowel cancer. Sadly, it's something that's been increasing quite dramatically in younger Aussies. So we're going to speak to an expert and find out why that might be happening. and just how we can better prep ourselves and get ready for the test.
Looking forward to it.
You know what test I'm talking about, right? The poo test. It's not fun, but we'll give you some hints on how to make it a little easier. We'll also be catching up with influencer Tammy Hembrow about her skin cancer experience. It's left her with a pretty significant scar on the back of her leg. And just like Dr. Long told us, for Tammy, it was in a place where it affects a lot of women on your calves.
Yep.
So we're going to talk to her about that and what it's like to recover from it, and now how she feels about that spot because, you know, she's an influencer and she's in front of the camera and her body is on display. So we'll catch you for your appointment next week.
Bye-bye.
Well is produced by me, Claire Murphy, and our senior producer, Sally Best, with audio production by Scott Stronach, video production by Julian Rosario, and social production by Ellie Moore.
Mamma Mia acknowledges the traditional owners of the land we have recorded this podcast on, the Gadigal people of the Eora Nation. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander cultures.